Hello, and welcome to Aurora IQ launch webinar. My name is Laura Piila. I'm the Vice President of Devices at Optomed, and I will be hosting our event today. We are proud and excited to be here today. Most of you are already familiar with Aurora, the state-of-the-art handheld fundus camera, and you're about to learn of many new and exciting features that we have developed and are now launching as Aurora IQ. We have 4 wonderful and talented speakers lined up for today. During the presentations, you can type in questions in the chat box that you can see on the browser screen, and we'll have time for a short Q&A session after each presentation. So to start off our show, I would like to call to the stage a visionary man who has been working for the past 15 years to enable screening everywhere for everyone. He is Optomed's founder and CEO, Seppo Kopsala, and he will now give an introduction to Optomed.
Thank you. This is a big day for me and for the company. So I'm a founder and CEO of Optomed. My name is Seppo Kopsala, and I will give you a brief introduction about the company and the product what we are launching now. Optomed Aurora is a handheld fundus camera integrated seamlessly with AI, and this product is to screen faster and more efficiently and very high quality diabetic retinopathy and other blinding eye diseases. In my speech, I will address on 4 parts about the market, what Optomed is today as a company, a little bit about our history as well, what is Aurora IQ, and what is our approach and how we see the future of AI in screening of blinding eye diseases. Global megatrends are constantly increasing the need to screen eye diseases. Population around the world is aging and growing, and at the same time, amount of chronic diseases such as diabetic retinopathy continues increasing quite rapidly. This all increases the need to screen blinding eye diseases. Blindness continues growing, and a lot of this blindness is avoidable if we can detect it early enough and treat early enough. On the other hand, new technologies such as AI has been advancing rapidly within following years. It means that right now we have tools available that can potentially provide an answer to this bottleneck of resources. Diabetic retinopathy is the most common reason for blindness in working age population around the world. Therefore, governments around the world have established national screening programs to address diabetic retinopathy. It means that people are being invited once a year or once in every 2 years to have their eyes examined. Usually the examinations have taken place by using a traditional large stationary desktop fundus cameras, and images have been read by a professional eye doctor. The challenge is that these resources are not accessible and not necessarily affordable for all population. These are the numbers in different countries that are showing the percentage of the people who are frequently being able to access these screenings. UK has a very well established functional screening program, able to reach 83% of the population. Germany is today around 68% of all their diabetics. Italy, depending on the area, numbers are less than 50%. Spain, there are big differences in less populated areas. The percentage are around 30%, and in highly densely populated area, they are able to reach 80% levels. United States nationwide, less than 50% of diabetics are having their frequent eye examinations. In France, for example, number is low. National level reported only 11% of diabetics go to annual or biannual eye examinations. And when you go to countries such as China, India, where hundreds of millions of diabetics and the number is growing all the time, the percentage is still very, very low level. So there is urgent need to increase the screening coverage. One reason why it is so difficult to reach all the population who are in need for screening is that the cost of the screening becomes higher when you go to less densely populated areas. Today, over 1/3 of the diabetic population lives in rural areas. This means that these people are harder to reach and they have harder access to frequent eye examination. That means that the blindness continues increasing rapidly, especially in those areas. Today and last 20 years, the golden standard for screening of diabetic retinopathy and other eye diseases have been eye clinics where stationary fundus cameras have been placed, or optometrists in many Western countries. But that means that then all the people need to go to these one central locations. And in order to get affordable screening, the patient volume needs to be relatively big for these units. That leaves many less crowded areas with a lack of screening. So what Optomed is doing with our products is that we provide easy-to-use, handheld, lower-cost cameras connected with AI. So we are removing these bottlenecks from smaller clinics to enable high-quality screenings. We started Optomed in 2004 with the goal to help to eradicate avoidable blindness in terms of retinal diseases that can be screened and treated early, namely diabetic retinopathy. At the same time, our products are being used to screen other eye diseases such as AMD, glaucoma, and many others. Since that, we have been a pioneering company in area of handheld fundus cameras, and we have expanded during the years our offering to cover also comprehensive screening solutions, including image management and screening program management solutions and telemedicine solutions. And now, within recent few years, AI has been a major part of our offering, and we see that that's the future of our company as well. Besides our own branded products, we have been selling our products through our OEM customers, which are well-recognized leading ophthalmology companies such as Carl Zeiss, Topcon, Volk, and Hugstrite. These well-recognized companies are complementing their product portfolios by adding our handheld cameras and selling on their label as well. Our production is made in cooperation with the global EMS company that ensures manufacturing of the high-quality products in a very cost-efficient way and in quantities that enable us to reach tremendous economies of scale. This has made us the leader in handheld cameras. Our products are well patented. We have a totally unique optical and illumination system in our camera, which is protected by 56 international patents approved in all the key markets. Our products are approved in the United States by FDA, in Europe by CE, in China by CFDA, and we have many other country registrations already existing, such as Japan, Korea, etc. We have offices and people in Finland, San Francisco, and Shanghai, and around these countries. 110 professional people in R&D and commercial are working for Optomed. On top of that, there is our production. Big milestone was reached in December 2019 when we took the company public in Nasdaq Helsinki main list. That was a tremendously good achievement and big milestone for a pioneering company like us. We got the financial resources now to really start commercializing our products in a way that has not been possible before. Today, our company has two complementary business segments. devices and software, and Aurora IQ, which we are presenting today, is combining these both solutions. That's the product that we are going to commercialize globally through the network of our distribution channels in over 60 countries. We have, during the years, we have developed a wide range of products. Some of them we are selling on our own label, and some of them are going through our OEM channels. And the products are seamlessly integrated with our software solutions, which we call Optomed Avenue. That's a screening process management software, image viewer software, and telemedicine and AI solution. Optomed Aurora IQ is now the camera that is easy to use and fast to use. That enables screening of diabetic retinopathy faster and more cost efficiently and accurately. And this is the product that within short training, any doctor, nurse or technician can start doing DR screening. And not only it is easy to use and reliable, but it's also easy to acquire in a very simple business model. We offer fixed pricing on our AI service for unlimited use. And this is the commitment and investment what we are doing as Optomed to push this technology through the market. In order to make sure that our AI is up to its job, so we work with in a global level with multiple research teams and startup companies and other AI companies. We choose our technologies and partners based on multiple principles. Clinical validation is definitely number one. We only promote the solutions that are clinically strongly validated and reliable. In addition, many other aspects must match in order us to integrate the AI into our products. And in later speeches, our experts are explaining what we have chosen for Aurora IQ and why. The future of our products and AI solutions is that first of all, screening of eye diseases will become automated. This is what we firmly believe. Very soon, AI is way exceeding capabilities of eye doctors in screening and diagnosing of any blinding eye diseases, and later on expanding to other disease areas as well, which also can detect it from the retinal image. Aurora IQ is the product that is enabling all these functionalities. Today, we are starting with diabetic retinopathy and later expanding to AMD and glaucoma and other eye diseases. So I'm very happy that we have reached the point where we can now introduce this solution, and I'm ready to receive questions if you have.
Thank you so much, Seppo. We do have a couple of questions for you. To start off, how is the Aurora IQ and the AI service priced?
Aurora IQ is the same price like our earlier Aurora camera. But right now, what we have done is we have paid all the AI service for top of that. So basically, whoever buys our Aurora IQ camera, we will provide for 1,000 first customers free of charge AI for unlimited use for 2 years. After that, the price of the service is about less than €1,000 per year.
Good, thank you. How about how many handheld cameras have you already sold globally via your different sales channels?
We have been the biggest volume manufacturer of handheld cameras for multiple years. So far, we have sold way over 10,000 cameras globally.
Great. And then the last question for you, Seppo. What is the most important criteria for selecting the AI partners you work with?
Clinical evidence is number one. This is the thing that we have never compromised. We started connecting our cameras to AIs already 10 years ago. We knew that many of these solutions already in that time technically worked, but it just took a long time to get the sufficient clinical evidence that prove that the AI can match or exceed the capabilities of the human eye doctors. So this is number one. And then the others that you need to have good match with our products, and also the commercial aspects must work. The AI must be delivered to the customers in a convenient and easy and affordable way.
Very good. Thank you. Those were all of the questions. So thank you very much, Seppo.
Thank you very much.
Okay, so we are moving on to the second speaker of today. That is Petri Huhtinen. Petri is the clinical director at Optomed. He is a molecular biologist, and he holds a doctoral thesis on in vitro diagnostics. He has been developing screening tools from the last millennium. He's an advocate of preventive health care and a big fan of screening. Petri will now give us an introduction to the new features of Aurora IQ.
Thank you, Laura. Thank you for providing me the opportunity to introduce our newest product, Optomed Aurora IQ, to this audience. It's a privilege, and I'm really happy to have this chance. We are bringing intelligence in retinal screening, and then I will explain you in the coming 30-40 minutes about the reasoning of the name and how we bring intelligence into the picture. I have divided my talk into three sections. First, I make my case clear. So I talk about the diabetics and eye screenings. Then I move to the product section, talk about the Optomed Aurora IQ itself, tell you about the features, capabilities. And then in the last part of the presentation, I will focus on maybe the most exciting new feature, the AI integration of the camera. So how we are combining handheld retinal cameras with artificial intelligence. Diabetes and eye screenings, I claim that it is an unsolved global mystery. Why is that? If we look at the numbers, globally, today there are more than 400 million diabetics. International Diabetes Federation has estimated that the number is growing, and in 25 years, there will be more than 600 million people with diabetes. That is a huge number. It is roughly about 8% of the global population. And if we think of the adult population, it is more than 8%. So roughly 1 in 10, 1.5 in 10 people will have diabetes in 25 years. With these 600 plus million diabetics, all of them will also have risk of other complications which are connected to the diabetes. They may have generate issues with kidneys, with cardiovascular system, and with their eyes. And roughly 1/3 of the diabetics will have diabetes retinopathy at some stage of their life. The diabetic retinopathy, it can be mild, but it can be also very severe. And in the worst case, if not treated, if not managed properly, it will lead to blindness. So obviously, a life-changing and life-affecting severe disease. Only 1/3 of the diabetics will generate the disease, but we don't know which of them. And therefore, all of the diabetics should have their eyes screened regularly. Through screening, we can prevent diabetic retinopathy and pick it up in the early phase of the disease, which means that you can, of course, it will be easier to treat, but you can also avoid the severe consequences and, of course, avoid blindness. So all diabetics should have their eyes screened regularly. At the same time, if we think of the specialist taking care of these diabetics and their eyes, so ophthalmologist, as it has been in the traditionally organized, Resnikov and colleagues estimated or calculated that there's roughly 250,000 ophthalmologists globally. 250,000 ophthalmologists. At the same time, now there's more than 400 million diabetics, and the number is growing and estimated to be 630 million in 25 years. So there's a huge mismatch between the number of ophthalmologists and diabetics. And with that said, we need to keep in mind that, of course, these ophthalmologists have other vision-related diseases to take care of. They are not only following the diabetics and their eyes. So that makes the resource scarceness even worse. If we look at the map on the screen, the darker the color, the fewer the ophthalmologists per capita there is. Meaning that, for example, in Africa, India, parts of Asia, where the color is very dark, almost black, there is very few ophthalmologists with a high population. Looking at Americas, Europe, the colors are lighter, so the situation is better. With that said, we need to keep in mind that, of course, many of the lower middle income countries are also in these same regions where the colors are very dark, so where the number of ophthalmologists is very low. In a way that makes the resource or generates even higher lack of resources, and it makes it even more difficult to have access to proper eye care. So having access is one thing, but even if you would have access, then it might be that you cannot afford it due to the fact that the demand is so high that the price of the healthcare increases, and affordability is lacking. So, huge lack of resources, and to even make it worse, most of the ophthalmologists are in the higher income countries, where the highest populations with the highest absolute number of diabetics are in the lower middle income countries. Something needs to be done to solve this accessibility and affordability mismatch. To conclude my first session, so it is obvious that accessibility to eye care is not enough. It's insufficient at the moment. And if there's no accessibility issue, there might be and often is affordability issue. We need to solve these things. And this is something we've been working as a company for 15 years already with our handheld devices, with our telemedicine solutions and other software solutions. We have been tackling the issue already for a long time. We have provided high quality handheld devices and IT solutions that can be used to transfer the images, digital images, from one place where there may not be human resources available to a place where we do have experts, and then return to result. But we feel and we know that we are not there yet. More needs to be done. And there's a lot to done. And our next step to tackle this issue is Optomed Aurora IQ. This is the device that we are launching today, and we think that now we are taking another step towards solving the global solution or issue of diabetic eye screening and other eye screenings too. When I talk about the product itself, again, I will divide my section in 3 subsections. First, a few words about the image quality upgrade that we've done. Then I will tell you briefly about the other intelligent features of the improved usability, or further improved usability. And then in the end, I will focus on the connectivity and how we are bringing the AI closer to the people. So we've done image quality upgrade into the camera. Optomed Aurora IQ looks the same as Optomed Aurora does. So when you have the camera in your hand, it looks the same. However, if you look at the images on the screen, the ones taken with the previous version on the left, and they are good quality images. But now with the current new optics, we are making it even better. We are focusing on the contrast so that we can bring up the veins, the circulation system more visible. And this is not photoshopping. This is not digital change. We are actually improving the lenses, the optics inside the camera to make it better. So the improvement is true improvement, not playing with the pixels and resolution. We know that if we want to take the eye screenings to the primary care and have the cameras in the hands of people who are not used to take retinal images, the usability is an important topic. And we've been working on the usability since the beginning of our company's history. And to be honest, we are still working on it, and there will be even more to come. But in this version, there are a few things that we are bringing in. So first of all, there is automatic image exposure. So instead of adjusting the brightness of the flash, you can use the automatic function so the camera detects the pigmentation color of the patient and adjusts the image so that it will be good quality when taken when the automatic function is used. The other feature that we want to emphasize here is the user locking option. We are talking a lot about patient data security nowadays. There's tons of big bits, megabits flying around the world with very sensitive data about us all. Therefore, also when we deal with the health data, it's extremely important that we focus on the patient data security. Here with new Optomed Aurora IQ, we can set up a user login requirement so that you cannot just pick up the camera and start taking images, but you have to have access to it. So you have to have a PIN code, personal PIN code, that you type in to be able to use the camera. And in this regulatory environment where medical devices are used, often authorities ask for audit trail. So the camera owner, the institute, the hospital, the primary care center, they may need to be able to show who has been using the camera. So now having the logging feature activated, it also enables audit trail functionality. And then just a nice small usability thing, we've added a watermark to help with the orientation. Here I have an example of the automated auto exposure function. Looking at the image on the left, it's been taken with the manual setting on purpose with incorrect brightness, whereas image on the right is been taken with auto exposure on. So you can obviously see the difference. And here on the left, it shows how one can set up the login information or set the PIN code requirement so that whoever is using the camera needs to log in first with their own PIN code. This is optional feature, so it doesn't need to be used. So if there's only one person using the camera, it can be turned off. but we feel that it's important feature to have there to ensure the patient data security. And the watermark that I mentioned earlier is shown in the highlighted in the image on the right. So with all of Optomed images taken with Aurora Optomed IQ, Optomed Aurora IQ, there will be our logo on the right upper right corner of the image to help orient the image in a correct way. Then a couple of words about the connectivity. So Optomed Aurora IQ is now improved in a way that it can be connected to a server, cloud-based server that communicates with AI algorithms. And of course, it is something that is necessary to be able to do actually what our new product is doing. We can generate cloud connection to our cloud service, which allows images and results to be moved around. I'll talk about that in a while. And then what's also important, the results will be returned on the screen already. So the initial screening result can be shown on the screen. But a couple of more details about Optomed Aurora IQ with the integrated AI and a couple of words about our Optomed's AI vision. So this is where we are going to. We think that, of course, today there are algorithms commercially available for diabetic retinopathy and for some other eye diseases. However, it's been known for a long time, 15, 20 years already, that eyes or retina are also showing similar features anatomically, physiologically, that our cardiovascular system is showing and our neurological system is showing. So therefore, with current computer-based tools, with machine learning, deep learning, we can actually assume, or we already know, that there will be algorithms for other than vision-related disorders. And there has already been some publications available where they talk about cardiovascular related algorithms or other systemic disease. And we think that in the coming years, there will be a selection of algorithms that are provided by our partners, validated partners, which we can then communicate through our cloud so that our devices anywhere in the world could communicate through the cloud service with any of the AI algorithms that we think are helping the end users, helping the people, the patients, to prevent severe health consequences. So this is where we are heading to. This is future. This is not today's thing that we would have algorithms for severe systemic disorders, but that's where we are heading to. However, where we are already today is having algorithms connected with Optomed Aurora IQ for diabetic retinopathy. And as Seppo already mentioned in his talk, we are very critical when working with different AI partners or AI companies. And we start by checking that they are clinically relevant. We and our partners need to be very ambitious with the clinical relevance of the algorithms that we are connecting with Optomed Aurora IQ. Today we are talking about one prime example, and we have Professor Daniel Ting talking in details about it, so I will not go into that yet. But we have several partners who are all going through the same tight process of being validated from the clinical perspective, having the right regulatory approvals already now or in their roadmap, having the technical compatibility with our products. Of course, it needs to be smooth from the end user to the AI partner's algorithm and back. And of course, also the commercial terms need to make sense for all parties, not only for the companies, but also for the end users, for the people who are using the service. And as said, today we will describe and introduce one of them, but there are several. We are working with different partners in different parts of the world for different purposes, but all of them will be rated with similar process, and we only want to work with partners that we can trust and who have the same objectives and mission as we do. And this is what's happening in practice. So there's Optomed Aurora IQ on the right of the screen. We take the image. The images or images are sent to our cloud-based server, which communicates with the algorithm company's server. The images are analyzed on the left side of the screen, and the result is returned back to the camera so that we actually have the screening result for diabetic retinopathy on the screen of the camera within a moment. Of course, how long does it take depends on the internet connections. Typically, with deep learning algorithms, it's a matter of seconds. With machine learning algorithms, it's a matter of tens of seconds. But certainly less than a minute if the internet connections are at least reasonable quality. The partner that we are introducing today is Iris, a Singaporean company, and their algorithm called Selena Plus. I'm sure Professor Daniel Ting, after me, will talk much more in details about Selena Plus, but I still want to spend a couple of minutes talking about it. So it's based on deep learning technology, deep learning system, and it's been developed using roughly 500,000 retinal images. First training the algorithm and then validating it. And what's the beauty, or one of the beauties of Selena Plus is that when they were developing the algorithm in Singapore, they were not using only Singaporean images, but they were using image sets from several ethnic groups from several different parts of the world to make it more universal. The algorithm was originally published in 2017 in JAMA. Professor Ting was the first author, and the corresponding author was Professor Wong. Selena Plus recognizes 3 different vision-related disorders: diabetic retinopathy, glaucoma suspect, and advanced age-related macular degeneration. However, in this first phase, we will be launching diabetic retinopathy only with Optomed Aurora IQ. And this is part of the clinical validation and clinical process that we will do. We feel that we need to have more clinical evidence with our camera from different ethnic groups for glaucoma and AMD, so that when we launch the system with all 3 instead of 1 only, we feel comfortable, both us, the camera manufacturer, camera provider, and Iris team, that the system, the combination works, and the end users can really trust on the result. At the moment, Selena Plus is approved of course, in Singapore, their home market, but they also have CE marking and Anvisa approval from Brazil already. So it is being taken into use globally as an algorithm. Selena Plus is a screening tool. So when we use it with Optomed Aurora IQ, there are 3 different result options. The result can be non-referable, which refers that there's no apparent retinopathy, or there's very mild non-proliferative DR. The result can be referable, which is presented on the blue box on the right. So referable DR would mean that the person has such changes in their retina that it would be important to go and meet a specialist. And then the third result option is ungradable, which would then mean that the image quality was not high enough for the algorithm to do the analysis. So there are only 3 result options. Either you don't need to do anything, non-referable, or you need to take some action, which is referable, go and see a specialist, or it's ungradable, and then you need to take another picture with better technical quality. The criteria is based on the International Classification Diabetic Retinopathy Scale. So Iris and us, we are using terms that are internationally acknowledged. This takes me into my second slide with conclusions. As I said in the early phase of the talk, there is not enough human resources to manage diabetes-related eye care. More than 400 million diabetics already now. It will be more than 600 million in 25 years. And the number of eye specialists is way lower, and they are not equally distributed, leading to a situation that highest number of diabetics who would need the eye screenings most are in countries and regions where there's the least number of ophthalmologists and other specialists. So something needs to be done. Conventional solutions are not enough. They are good, they are needed. We are not throwing anything away. We want to add something. And we think that artificial intelligence combined in an intelligent way in retinal imaging can be the game changer. When implemented properly, it can provide access to regular eye screenings, even in the regions where it's not possible today, in such a cost that it could be afforded. And we, Optomed, together with our partners, we want to be part of that changing game now and in the future.
Thank you, Petri. We actually have a number of questions for you. First off, there was a question from the audience of how many megapixels does the Aurora camera imaging sensor have?
It has 5 megapixels.
Very good. Then there was another question of how you talked about the machine learning and the deep learning for algorithm development. And there was a question of how is the Selena Plus algorithm developed?
To be honest, I know, but the next speaker will know even better because he was developing it. But Selena Plus is deep learning based algorithm. It was developed in Singapore. They used roughly 250,000 images to train the algorithm, and then they used another 250,000 images to validate the algorithm. So they, in total, they used about 500,000 images when developing and then publishing then finally in JAMA in 2017. But I know that Daniel Ting, the next speaker, will talk more about it.
Very good. Then there was also a question on, you mentioned also the glaucoma AI, and there was a question of why referable glaucoma suspect, and the suspect being the question of why is it a suspect?
I'm a big fan of screening, as I said, and I've been doing it for a long time. And it's important to remember that screening is not diagnostics. Screening is something where you provide suspect. You look for risk population, And once you find the ones who have increased risk, then you tell them, please go and have a diagnosis. So therefore, it's always, in screening, it's always a suspect. People often forget it, but it is so.
Very good. Then there was also a question of is the Aurora IQ more user-friendly? Can you create a patient faster than with the Aurora Now?
I think with the Aurora Now and with the Aurora IQ, once you start using it, after a very short time, you don't even think what you need to do. Both are user-friendly, and we are, as said, working all the time to improve the usability. And now we are bringing in a couple of more features to improve the usability. So I would not see that as an issue. If you are using the camera on a regular basis, it will be very simple with Aurora IQ as well.
And in this same question, there was actually a follow-up that where the person who asked the question doesn't know if in their country a doctor can provide the patient details and the picture to a third party, being the AI for the analysis. But can you elaborate on how we do the image transfer or if we include any patient data when transferring the images to AI?
Well, there's the image is transferred without any sensitive data. The images are combined with the patient data, not in the cloud, but locally at the doctor's office. However, I think these are the things that you always should study carefully in your local environment, because every country is having their own regulations, their own legislation. And it's a fact that artificial intelligence, especially in ophthalmology, is still a new thing, or relatively new thing. So also the legislation and rules are changing. So therefore, it's very important to understand the environment that you are working in and then follow the rules. And I'm sure that with our system, we can help you to follow the rules.
Very good. So Petri, then the next question. Do you have any clinical evidence comparing handheld cameras to desktop cameras in screening for DR and other eye diseases?
Yeah, thank you. So us and others have been providing handheld retinal cameras to the market for a few years now. And then when getting ready for the webinar, I checked the databases. It seems that the first publication where our camera, our previous SmartScope Pro, was compared against tabletop camera came out 2017. So since then, there's been comparisons between handheld devices and other devices. With Optomed Aurora IQ, we haven't published anything yet, but we know that there are a couple of papers in a review process at the moment, and we are working with a few others. So of course now in today's world it is important to first, of course, we want to validate the system clinically that it works, but we also want to show it to our customers, stakeholders, that it's clinically valid, and therefore we will be publishing these results once they are available.
Very good. Another question, are the Selena Plus AI and the Aurora IQ camera available in all regions?
Technically, they are. However, now if we think of the process of the validation process I showed, the second step was regulatory roadmap or regulatory approvals. So unfortunately or fortunately, different countries, different regions have different regulatory bodies, different authorities deciding, making decisions. So therefore, we only will be providing the combination in the countries where they are approved. Today, Selena Plus is approved in Singapore, in CE region in Europe, and also in Brazil. Not every country requires their own approval. So in many places, CE marking, for example, is enough. So, for example, I know that in many African countries, CE marking would be just enough. Optomed Aurora and Optomed Aurora IQ are globally widely approved by different authorities. So whenever they are used in combination, then you have to just make sure that both parts are approved.
Okay, thank you. Then is there a report generated by the AI?
Now, as I said, the result will be shown on the screen of the camera. And then I will not answer to this question yet because we have another speaker coming up who will be talking about Optomed's software solutions and the newest things. So as said, Optomed provides not only handheld cameras, but also IT solutions, and we will have solutions for that as well.
Great. Then we have one more question. When can we expect to have other algorithms besides for diabetic retinopathy to be integrated into the Aurora IQ?
Into the Aurora IQ, we are now working on AMD and glaucoma, which are already part of the Selena Plus. We are validating them, and I'm a very conservative scientist, so I say that they will be available in the first half of 2021.
Okay, that would be all of the questions. Thank you so much, Petri.
Thank you, Laura.
All right. There was actually another question which I can answer to, because there was a question from the audience of if we could repeat the part about the pricing. So Optomed will provide for 1,000 first customers the Aurora IQ together with 2 years unlimited AI use included in the purchase price of a new camera. And the purchase prices, of course, can vary a little bit from market to market, and we have a very wide network of distributors that you can reach to get the pricing locally. So then moving on to the third speaker of today. We are very honored to have such an expert in this field speaking in our event today. His name is Dr. Daniel Ting, and he is the Assistant Professor of Ophthalmology at the Singapore National Eye Center. He is also a member of Optomed's Clinical Advisory Board. Daniel has a very wide bio and great achievements. To just tell a few things about his professional experience, to date he has published close to 80 peer-reviewed articles in highly ranked journals such as JAMA and Nature Medicine. He's also a co-founder of the SNEC spin-off company Iris that has developed the Selena Plus algorithm that we have now integrated into the Aurora IQ camera. We will now have Daniel joining us from Singapore to give us more insight into AI in eye screening.
Hi, everyone. Thank you for the kind invitation to speak today. My name is Daniel. I'm currently working at the Singapore National Eye Center. This is one of my financial disclosure. I'm currently one of the scientific advisor for Orchitrax, and I'm also currently serving in the AAO AI Task Force, START AI Task Force, as well as a few editorial boards as well. So I'm just pleased to share that AAO has just set up the AI Task Force in 2019 in San Francisco. And as you can tell from the right hand side, Professor Michael Chang has also just been recently been appointed as the director for the National Eye Institute. So before we actually get into whether AI could replace ophthalmologists, let's speak about whether the AI could actually replace humans. And in fact, I actually got these questions a lot of times from some of my friends. 4 years ago, when the news came out, the world best Go player has been beaten up by the AlphaGo. It has shocked the world. So basically, the world best Go player has been beaten up 3-0 straight match, and the paper has also been published in the Nature, the publications. So just 1.5 years later, the enhanced version called the AlphaGo Zero has beaten up the same machine in just 40 days. The scary thing about this enhanced version is that it no longer needs human intervention. It no longer needs structured data to train. And this is a technique, what we call it as deep reinforcement learning technique, and they actually learn in an unsupervised manner. So how is this going to be relevant to the scientific field? So if you look at the protein prediction, if you ask a human to manually calculate the proteins, how the proteins can fold and unfold, it takes 13.8 billion years. So deep learning could potentially expedite this in a much faster manner. And how is this going to be relevant to us? So potentially we can use this technique to predict some of the therapeutic targets for new drugs. And not only that, we could potentially modify some of the disease prevalence or progression of the disease using gene therapies as well. The second question is, can AI see what we can't see? And 3 years ago, same period of time, Google has published this paper using fundus photos to predict the patient's age and gender. When I actually had the privilege to review the paper, I was asking myself, this cannot be true. So what we've done is we requested the AI algorithm to be tested using the Singapore data sets. And in fact, the testing result is consistent with what Google has published in the paper. And hence the publication was accepted in Nature Biomedical Engineering. The highlight of this year as well is another group in Google DeepMind, has collaborated with Moorfield Eye Hospital and in publishing this paper in Nature Medicine as well. So basically using deep learning and the patients with neovascular AMD, the fellow eye, now deep learning could potentially predict what's the risk of the conversion risk from the dry AMD to the wet AMD. So this is pretty powerful when we want to actually develop some of the preventive medications. And as we know, currently we are in the fourth industrial revolution. We have gone through the steam era, electricity, computing, and now we are in the AI and deep learning. And AI is nothing new. It started back in 1950s, and machine learning term has been coined back in 1980s. And the new kids in the block is called the deep learning that has been introduced 10 years ago. If you talk about deep learning, you cannot get away without these three godfathers, namely Joshua Bengio, Geoffrey Hinton, as well as Yann LeCun. Jointly, they have won the Turing Award, which is the Nobel Prize equivalent in the computing world. They have published this paper back in 2015 in Nature that has been cited more than 40,000 times now. And they state that the deep learning allows the data to be analyzed with multiple processing layers with multiple level abstraction. If you break down the CNN, which is a neural network, it can be broadly divided to the input layer, hidden layer, and output layer. And most of the CNN differ in the hidden layers, which is the middle layer. And also you can see the size of the numbers of the layers has increased tremendously from back in 1989 to all the way now from 7 layers to about 1,000 layers now. And the newer nets tend to have increased layers, smaller convolutional filters. They have some special functions called the skip connections, and they could also have the bottleneck connection and dropout as well. Deep learning in medicine, as you can see from the graph, has actually increased tremendously over the last few years in different domains, different target tasks. And why do we need AI in the clinical world? Is it just because it's sexy? Is it, and it's not really that case, because we know the world is experiencing the aging population. People are getting older. We have more problems, and more people require medical care, and there's a shortage of the medical expertise, and the medical cost is also rising globally as well. Taking diabetes, for example, by 2040, 1 in 10 people will have diabetes. And what about in Africa, the low to middle income countries? And by 2040, they will have 34 million people who have diabetes. And how is that going to translate into, say, a country like Zambia, that is a country in Africa as well? In Zambia, if you can see, 1 million population, you only have 3 doctors, and we're talking about 3 general doctors and not even ophthalmologists, not retina specialists, 3 medical doctors. How is it possible to train these doctors to know cardiology, ophthalmology, dermatology, gastroenterology, and whatnot, right? So how is it possible, even possible, to be able to screen these patients' eye in these countries? This is one of the severe unmet need, globally speaking, at the moment. And we know the world were severely struck by COVID-19 pandemic crisis this year that has caused more than 35 million deaths worldwide and more than 35 million infected people with more than 1 million deaths worldwide. What are currently some of the implications in the global healthcare landscape? First, it increased the public and staff exposure risk. Second, it increased the waiting time of the patient in the hospital. And some of the patients suffering from delay of the treatment, also partially because many medical staff have been deployed to the front lines. And earlier this year, joining together with Dr. Lawrence Kareen, Victor Zhao, and Tian Wong, we have published this paper in the Nature Medicine, which has also quoted by the US CDC as well. So in the paper itself, it states the importance of the AI and digital technology in mitigating the risk of COVID-19. As we all aware, AI is highly interconnected with big data, virtual health, and how can all these data transfer and stuff be encrypted by blockchain? This is some of the things that we actually discussed in the paper. And we actually highlighted a few examples, including Johns Hopkins COVID-19 dashboard, the AI for risk modeling, as well as the CT imaging for COVID-19 as well. In ophthalmology, we have also published major review articles 3 years ago together with the world AI experts in ophthalmology, stating the state-of-art ophthalmology AI technology using fundus-based imaging in detection of diabetic retinopathy, glaucoma suspect, age-related macular degeneration, as well as ROPs, and also OCT-based devices on glaucoma and retinal conditions as well. Just 2 months ago, we have also published another papers looking at how AI could be interconnected with the digital technology and telemedicine as well. It has also come out in the Progress in Retina Eye Research. Definition of digital health, how is 5G, 6G, IoTs, AI, machine learning, deep learning could actually interconnect with each other, how these digital technology could be actually applied in many different eye conditions. What are some of the emerging digital technologies such as the home monitoring devices, AR, VR technology? How could these be applied in the digital innovations, clinical lab, and how is these going to be relevant in the post-COVID-19 new normal? And what are some of the challenges for clinical implementations as well? So these are some of the few papers that have come out in the earlier years, including the Gushan et al., the first paper in deep learning for diabetic retinopathy. Our paper in Singapore were published like 1 year later in JAMA as well. DeFoyer and Abramov has also published the deep learning system in both OCTs and the US FDA approval studies as well. So I just wanted to actually share, when we write or when we read the AI paper, what are some of the important components that we have to be aware of? So we actually published this as an editorial in ophthalmology in 2019. For those of you who are interested, please feel free to read it. And in the article itself, we went through from the start to the end, how should we actually, read the paper. So first, is this study answering a question that matters? Is it what clinical unmet need we're talking about? Whether the authors have actually done enough literature review to know what value add is this current AI system is adding to the field. Second is, what are the core components in an AI system, and what are the training, validation versus the testing data sets? What are some of the clinical data sets and the technical network that are very important to be told to the audience? And what makes a good training and testing data sets as well? I often get asked, what numbers is enough? Can I train an AI system? What are the breakdowns of the patients and the images in the study? And what makes a good reference standard? How was the training versus the testing data sets are graded? Types of the graders, experience of the graders, the numbers of the graders, and we really have to avoid the phenomenon called the garbage in, garbage out phenomenon. What are some of the appropriate machine learning versus the deep learning technique that's really important? For clinical data, we could potentially use the conventional statistical approach, machine learning, such as the random forest, support vector machines, and the deep learning with for those with temporal sequence. And image-only ones, we can actually use deep learning and genetics data. We use the machine learning, and the multimodal we can approach can be used for clinical data, image, and genetics as well. What makes an excellent operational flow of an AI system? Then, I always use this analogy. Just imagine the patients coming to the hospital. Just imagine the patient's journey within the hospital settings. Same thing for the AI system. Just imagine when an image comes into the AI system, what is some of the very important the consideration factors. So the types of medical images, gradability, whether this image has a good or bad image quality, what are some of the pre-processing steps to augment the data sets, and what the CNNs is used in the data sets, and the generation of the output is really important, and how do we visualize some of the abnormal areas that the deep learning network is saying. And how do we clinically assess the diagnostic performance? This is another important areas. So based on US FDA guidelines, so the AI is going to be treated as a software and a medical device. And these devices have to be tested in the intended use environment. So what are the power calculation of the test set, the AUC, sensitivity, specificity, what are some of the 95% confidence interval? We need multiple independent testing data sets to know what the generalizability is of the AI system. We have to also be very, very careful that today the testing data set has to be analyzed using the preset operating threshold to avoid shifting the goalpost. And the accuracy, I just want to caution the audience as well. Accuracy does carry a statistical meaning. So it is actually defined as true pause plus true negative divided by true pause, true negative, false pause, and false negative. I just wanted to share that if today we have 100 images, 3 are positive and 97 is negative. If an AI system meets all 3, you can actually still get 97% accuracy, but 0% sensitivity. And this is how skewed accuracy can be. These are some of the examples that we've actually done in Singapore, published in JAMA, Nature Digital Medicine, and Lancet Digital Health. And 4 years ago, we started this study called the Deep Eye study. It is a multi-center AI study to look at whether we could use deep learning system to detect 3 potentially blinding conditions, namely diabetic retinopathy, glaucoma suspect, and age-related macular degenerations. So as I mentioned before, this is a multi-center AI studies involving different countries, different studies, different races, different retina cameras, and different reference standards as well. Using VGG19 as a convolutional neural net and close to 500,000 of images on DR, glaucoma suspect, and AMD, we showed clinically acceptable and excellent diagnostic performance in detection of diabetic retinopathy, glaucoma suspect, and AMD as well. We also further externally validated and tested the AI algorithm for DR in the global data sets that we got, and it also shows consistent performance as well. So we were lucky enough for the AI system to be publicized in Singapore, and it has currently been also included as one of the national AI strategy algorithms in Singapore as well. Right now, for the last 18 months, we have also integrated the Selena Plus, the AI system, into the national teleretina DR screening programs. And this is just one of the roadmap to actually highlight, from the AI training all the way to the implementation, the integration over the 5 years period. And currently, this is the reading workflow in our reading center. All the images will be read primarily by the primary graders. And for those who are deemed to be abnormal, then you'll go through to stage 2 for further confirmation. And now what we're trying to do is to replace stage 1 with deep learning system to analyze 100% of the retina images. And then for those who are detected as abnormal, then human will actually come into the picture. And for the pilot results, we actually done it on 12, close to 13,000 patients. And we actually show consistent performance with the JAMA publications. And while retaining the sensitivity, using human graders, it brings up the specificity from 84% to close to 100%. And we ran a health economic analysis as well using the Markov modeling. And we show that the combination of the human and the AI intelligence actually yielded the best economic output, and followed by the fully automated model. We also looked at how we could use AI-generated DR gradings to pick up the systemic association of the risk factors. So we actually done it on the 18,000 patients with 6 different races and from 8 study sites. We show that the AI versus the human have comparable sensitivity in detecting all the different systemic vascular risk factors in association with diabetic retinopathy, with the time taken of DLS much shorter than the human, as you can tell from the table. And we also looked at how AI could help with the low to middle income country where the expertise for screening is lacking. So this paper has also been published in Lancet Digital Health. And this is the example that I used previously in Zambia. And we actually, for this particular study, we upgraded the technical network from VGG to ResNet, as well as the Ensemble network. And then we again show consistent, good diagnostic performance in detecting referable diabetic retinopathy, vision-threatening DR, and diabetic macular edema as well. And this is some of the examples that shows the visualization techniques that the neural nets is seeing. And we also look at if we were to do digital health, virtual health, the storage capacity in order to improve the efficiency of the transmission of images. Sometimes it requires compression of the compression of the retina images. So we actually looked at if we compress the retina images down to a certain size, does it actually affect the deep learning system when they're actually trying to analyze them? As you can tell from the bottom right table, if you compress the image down all the way to 250 kilobytes, 200 or 150, you see the specificity actually would drop significantly from 90 all the way to 55. And if you look at the color fundus photos between the 350 versus 150, you literally can't really tell much pixelated changes. But however, when you actually run the heat map analysis, you know the 150 kilobytes pictures is showing a lot of pixelated changes in the fundus photos. And we also looked at how deep learning could be used to analyze the retinal vessels, and that is strongly associated with the cardiovascular risk factors as well. And in fact, we actually shows that deep learning, using deep learning to analyze the retinal vessels is a good way to look at the cardiovascular risk of a particular patient as well. Not only that, we also use the fundus photos to trying to predict patients with chronic kidney disease. And as you can tell from the right-hand side of the picture, we actually have showed a comparable outcome between the AI versus the human. Yeah. And the last one is the deep learning, using deep learning to detect some of the patient with the brain conditions such as a brain tumor or brain bleeding. And papilledema is defined as a bilateral optic disc swelling. And this is something very powerful, especially for those rural hospitals that do not have any neuroimaging facilities. And these could actually potentially be used as a triaging tool to triage the urgency of these patients getting transferred to the metropolitan areas as well. So some of the unanswered areas in AI included safety considerations, technical methodology, what's the business models, and the medical legal aspects as well. And Ali Rahimi is one of the famous Google scientists, and when he got the NIPS award, which is a top tier deep learning conference, and he actually states that machine learning is an alchemy. Why is it an alchemy? Because we do not know some algorithms work or some don't. There's no rigorous criteria for choosing one architecture over the other. In deep learning, some features that are deemed to be important are essentially useless for training. Many algorithms work better when those features are stripped away. And many of us feel like we are operating in on an alien technology. Some of the ongoing projects that we are doing, we're currently expanding the 3 conditions to other conditions as well. We're developing the OCT-based AI algorithms, some of the predictive AI algorithms, the GAN using the few shots and zero shots techniques as well. AI for genetics is also another areas that my team is looking at. And we also we looked at the natural language processing using the chatbot and also some of the virtual assistants as well. The future directions, I think the AI could be developed for portable cameras, such as the Optomed the Aurora, AI for home monitoring devices, the AI for AR, VR, AI for predictive algorithms, and AI for systemic conditions as well. So just wanted to spend a few slides talking about Aurora. So, I mean, the whole world is actually trying to see how we can compress and actually make the screening as portable as possible, as light as possible, and as user-friendly as possible. So I think this is one of the key strengths of Optomed to be designed as a portable and a light devices to screen for especially conditions for DR, and it's a non-mid that doesn't require pupil dilation and avoiding the risk of the angle closure glaucoma, especially in Asian settings as well. And the width of field is about 50 degrees. The color-wise is actually very similar to how we actually examine the patient under the slit lamp. And not only that, the electronic medical records that's getting linked up from the cameras, I think this is a very, very important, the powerful tool to actually be used as a potential, future AI training and validations as well. So, I mean, this is one of the announcement that Optomed has actually also incorporated some of the AI algorithms into the cameras. And I just wanted to actually share this also with the audience. And do you know which one is real, which one is fake? I always ask this, and literally no one actually could tell me about this. And literally A, C, and F are real, and B, D, and E are fake. So this is something what we call, again, using the generator and the discriminator to artificially synthesize the images. And this is useful to increase the diversity of the examples. And we could also potentially use this to rectify some of the data sharing privacy rules. And the future directions, as I mentioned before, the blockchain is something that my team is currently looking at, how we could actually leverage on the 5G, 6G, the satellite imaging, space technology, on the healthcare sector, the setting. I think this is a super exciting field. And not sure how many of you have read this Google paper. Literally, the quantum, the quantum supercomputing is something that could outperform GPUs by a lot. So taking the sampling one quantum circuit a million times, the classic GPUs takes about 10,000 years, when the supercomputing of using the quantum supercomputing actually only takes 3.5 minutes. So are we talking here now about Industrial Revolution 5.0? And what about the cybersecurity risk that's actually tagged along with this? So will AI replace ophthalmologists? Just back to the title that I was supposed to present today. If you actually do something really fun in the BBC, the URL, you can actually type this in. I am a ophthalmic optician, and you will be ranked less than 15% chance. So congratulations for those ophthalmologists who are on these webinars now. And I just wanted to know, also alert the audience that today we talk about AI, digital technology. Everyone is very excited. Everyone is very hyped up, but we shouldn't actually neglect the patients and the reports when we actually see the patients in the clinic. So this is a picture that's been painted by a 5-year-old girl when she went to see the pediatrician with the mother. So basically, this is something that a doctor is busy typing, on the EMR system, where they are actually facing his back towards the patient. So I mean, the patient's report, the human touch are still very important in this AI and digital era setting. And I would just like to strongly encourage everyone to remember that. And this is some of the Seri AI work that we've done for the last few years. And with this, I would once again want to thank my local and international collaborators and the organizers for the kind invitation to speak. Thank you very much.
I hope you can still hear us. We have some questions for you from the audience. To start off, the first question is, how accurate or confident is the result displayed on the screen? What if there is a false positive?
Well, I think that's a very good question. And really, if we actually look at the screening technology, whether it's AI, whether it's any diagnostic device, in the screening setting, we always need to kind of balance the sensitivity versus the specificity. So today, if we talk about the screening technology, we always prioritize the false negative rate. So we would try to reduce the false negative rate to as low as possible, for instance, for DR, because you don't really want to miss anyone with, say, proliferative diabetic retinopathy or severe NPDR. But of course, when you actually increase the sensitivity threshold, you are actually compromising on the specificity, as we know, because all these things is actually be playing around on the ROC curve. So what is the implication when you result in a lot of false positive detection, and worse still, false positive referral to the tertiary eye care settings? So I'm not sure whether you guys still remember one of the slideshow that I said. So combining the human intelligence and the artificial intelligence, the AI system in the hybrid approach actually yielded the best economic values. So why is that so? Because when the human comes into play, they can actually recorrect some of the false positive rate that the AI system is detecting, and then hence reduce the unnecessary referrals to the tertiary eye care setting. So if every single false positive patient, you will result the patient to be screened instead of being screened in the primary care setting to the tertiary care settings. So, I mean, the cost, as you can imagine, is actually going to be increased significantly. So, those are the balance between the sensitivity versus the specificity that usually we need to play around with. Yeah.
Very good, thank you. Then the next question is on Singapore, and when has Singapore started to screen diabetics at primary care?
Well, I mean, the screening exercises has actually been done long time back. I mean, say even before 10, 15, 20 years ago. So when we actually, in fact, starting from the ETDRS, the studies that was done like 30, 40 years ago, we know screening for DR does reduce the severe visual loss by to up to 98%. So basically, this has really started all the DR screening to be done worldwide since 40 years ago. But the screening in the conventional manner has been done in a clinic setting where the patient comes to the clinic, they will be seen by a retina specialist using the slit lamp examination with the 90D, 78Ds, the lens. Then there comes the retina cameras, there comes the teleophthalmology screening that actually has started off, say, 15, 20 years ago. And now the AI deep learning, the screening, I think that has actually started about 3-4 years ago. And then Singapore, as I've shown in the slides, we actually started running a national teleretina screening program in a non-AI manner since 10 years ago, starting from 2010. And right now we are in the midst of integrating the AI system. And then, in fact, it will officially start from next month onwards in the Singapore setting in a semi-automated manner, in a hybrid approach. Yeah.
All right, very good. Thank you. How do you see the future of AI developing? What do you think is the next breakthrough after DR, AMD, and glaucoma?
Yeah, I think for me, I shared that in my last few slides. I think predictive algorithm using the patient's baseline photo to predict what's going to happen in 5 years, 10 years, or even 15 years time, I think that will be super powerful. But unfortunately, right now, the papers that I've seen so far, the performance right now, we are looking at mid-70s, low 80s. So it's not super robust. It's not like the classification task that we're actually seeing about mid-90s, the standards. But I think like this is moving forward. We can actually explore more of the novel technical methods to actually, analyze more of the subtle changes in the, in the images. So that's number one, predictive AI algorithms. Second, I think the other portion will be whether we could actually bring the AI system from the desktop, from the cloud to the mobile setting, to the mobile solutions. I give you an example. I mean, just as if like the Sony Walkman, when people were using the cassette, the CDs, but now we're, the Apple iPod has just totally revolutionized how the music industry is working right now. And now we're talking about Spotify even, right? So, those are the things that, in healthcare setting, this is something that we should actually push towards. How do you make is exactly like what Optomed or Aurora is trying to do? How do we make the healthcare screening or diagnostic solutions to be more compact, to be on a more portable, more light, and then how do we even bring this to the patient's home? I think that is something that I would like to see that happening in the next few decades. Yeah.
That is definitely on our agenda as well. There is also a question from the audience. Do you think AI will definitely change the landscape of the screening of retinal diseases or for AMD or glaucoma?
Well, I think for DR, the short answer is yes. For glaucoma, not sure. Because, we are still struggling to find the cost effectiveness, to screen for glaucoma, because first, the disease prevalence is low. And then secondly, is the glaucoma definition. As if you can ask 10 different glaucoma specialists in the field, I think, 8 out of 10 would give you a different answers, based on one image that they see. And then AMD wise, when we screen, are we talking about having a preventive measure? So far, we haven't really quite seen any effective treatment to prevent the progression of AMD. We know AREDS 1, AREDS 2 is trying to recommend the formulations to prevent the intermediate AMD from advancing to advanced AMD, but the protective factor is the 25%. We know 1 in 4 people works, and in other words, 3 out of 4, people who took the formulations don't actually work. So, these are some of the cost effectiveness analysis and the clinical effectiveness when we screen a particular condition we have to be very careful about. So, I think to answer the questions, I think DR definitely would. And then whether or not, what about the OCT imaging? So again, it also goes back to the country-specific, the practice patterns. For instance, UK, the optometry practice, many of them have an OCT machine. That's why that's also the reason why the Google, the DeepMind group, as well as the Morpheus group, were looking at the OCT as a start, because that was a huge disease burden in UK and Europe. But having said that, if you look at the US or for Singapore, for instance, we don't actually rely so much on the optometry OCT-based screening algorithms, so those are the things that actually would differ from countries to countries. And in order to make an AI work, it goes back to what the US FDA has recommended. So it has to be used in an intended use environment. So really, I don't think there's one shoe that fits all. So we have to actually adopt a very bespoke and personalized approach when we actually talk about AI screening or AI diagnostic device in a healthcare setting. Yeah.
Very good, thank you. So then one last question to you, Daniel. Is the performance of Selena Plus the same in every ethnic group?
That's a very good question. So we talk about the generalizability here. So when an AI system is developed using a homogeneous population, for instance, Selena was actually developed using the Singapore population that makes up 3 different major races. So there's Malay, there's Chinese, there's Indian. When we actually tested against the 10 external data sets that I've shown just now, the consistency of the diagnostic performance was similar. But although, there's a small caveat there, because when you actually look at, you delve down to the table that we publish in JAMA, there's a variability in the diagnostic performance, even though they're all more than 90%, but some is in the high 90s, some in the mid 90s, and some in the low 90s. So the ones with the better performance usually comes from the same camera, same homogeneous populations, and the one that's a completely different, say the Caucasian eyes, the lightly pigmented fundi. So the AI performance, will actually dip a little. But having said that, to our surprise, it still managed to hit the clinically acceptable standards. Yeah.
Thank you, Daniel. Thank you so much for taking the time to take part in this event today. Thank you. So
Thank you
then
very much for having me.
It is time to call to the stage our last speaker for today. Her name is Vuokko Ihalainen. She has both a nursing degree on preventive healthcare as well as a bachelor's degree on information technology. She has worked for over 10 years on several different projects to digitalize and streamline healthcare processes. She's working as a product manager for Optomed software and is keen on making the latest technology effortless to use. There was also one other question from audience during the last speech about whether if a customer already has an Aurora camera, can they use the Selena Plus algorithm as an API? And there will be an answer to that question in Vuokko's speech, how you can also use the AI through our software solutions. So Vuokko will now give us an overview on the Optomed software solutions that complete the clinical workflow when doing DR screening with Aurora IQ.
Thank you, Laura. Great to be here today. I'm happy to introduce you new Optomed software solutions. Optomed software solutions are designed to streamline the workflows of eye screening. They are designed together with ophthalmologists and photographers. They are supporting different needs of camera users. Combining different systems together, we are trying to make the use of the Aurora IQ the most effortless and seamless to work together with other softwares which people may use. First, I would like to tell you about Avenue service. It's basically a web page where you can register your camera in use. From there, you can also see all the documents, agreements, etc. according to the camera. There's possibility to activate IE in use and see all the camera information. For admin users, there's also a possibility to see the usage of the camera and IE. Then we have a tiny software called Sync. Basically, it's a program which is working in the background. It helps the camera user combine the Aurora IQ into hospital information system. It integrates it in the background so that you kind of like think that the camera is part of the whole. Basically, Sync is designed to transform DICOM work list to the camera. And from the camera, you can actually send the images into the hospital image archive. So it takes care of the communication between the camera and the existing infrastructure. Here is described a little bit of the different parts of the Sync. You can insert patients via clinics or hospitals information system, and those are transferred via Sync into the camera. The list of the patient can be used as a work list so that you can easily and effortlessly take images with the camera. When you are ready with the imaging, you can send images into the image archive which already exists. For the ophthalmologist, they can see the images from their own system and use familiar tools for viewing images and creating reports. Avenue Sync is designed to use the work effortless. It's a simple application for photographer for adding study and patient information and sending images back to the image archive. If desired, you can quickly edit patient data or study data in the sync before you are sending it to the image archive. Also, images which are not desired to save, you can delete. It works together with the hospital information system so that everybody can use the familiar tools. Another Optomed software application is Avenue Viewer. It's an application which has its own standalone database for images and patient data. It's designed for reviewing images and creating reports and storing all in the same database. You can integrate this image viewer with AI and get the results combined into the report or medical statistics. Here you can see all the different parts of the viewer. We have the database where you can store patient and image data. Of course, you can add, delete, modify, enter new patients, studies with the user interface, which is designed to have as much as possible everything in the same page. If desired, you can create own work list via Avenue Viewer for Aurora IQ. Avenue Viewer can also be used with other producers' cameras. When you have taken the images, you can use embedded image viewer for analyzing images. There are different filters and tools for manipulating the image so that you can see all desired information from the picture. While you're looking at the images, you can also write report or send images into the AI for analysis. If you want, you can add the AI analysis as part of the report or just leave it as your own information. Avenue Viewer is a local database software which you can use for maintaining and storing patient and image data. It's working seamlessly with a connected AI. It gives you the possibility to view images via embedded image viewer and create medical reports. And basically, image viewer has it all.
Thank you, Vuokko. Thank you for the great presentation. We do have a few questions for you. First of all, do I need to install any of the software to be able to use Aurora IQ?
Aurora IQ can be used separately, but if you want to send images into a separate image archive or store them for yourself, you need to have software for it.
Very good. How about the next question? Could you repeat the differences between Avenue Sync and the viewer softwares?
Avenue Sync is designed to work in the background so that it's basically just working as a transmitter. between hospital information system and camera, so that you can get the patient information to your camera, do imaging as fast as possible, and send effortlessly images back to the hospital image archive. And Image Viewer is having everything in its own. So you can create patients, add studies, and images in the same system.
Very good. Thank you. Another question is, do I need to register to the Optomed Avenue to be able to use the AI in the Aurora IQ camera?
Yes, that's the correct place where you can activate your AI in use.
And the last question, Vuokko, for you. Does installing the Avenue Viewer require installation to any local computers?
Both of these are installed locally on your computer. So both softwares do have an own installation package.
Okay, very good. Thank you so much, Vuokko. Wow, what great presentations and great questions. We had such an active audience today. Very, very good. Thank you. On the webinar page, we have a feedback section, and we would be very grateful if you could take a minute to let us know how we did in this event. I would like to thank all of you for participating in this product launch. You will get a link to the webinar recording as well as materials on Aurora IQ in your email after this event. I also want to thank our speakers, especially our guest star, Dr. Daniel Ting. Now, let's embark on the AI journey and let the transformation begin. Thank you.